of programs for On Point NYC in New York City. And I was very honored to be the program development and implementation lead on opening the first 2 safer consumption sites in the United States. Very briefly, my background, I'm a dual citizen. I've been living in New York City since 2016, but I was born and raised in Canada and spent 12 years working in Vancouver, Canada, running and developing harm reduction programming there, including safer consumption programs, before relocating to the United States in 2016. So the 2 sites we opened in New York City were the 5th and the 6th drug consumption program that I'd have some sort of involvement with or had opened. So bizarrely, it's an area where I tend to have quite a bit of experience. The big question that we are all facing in the United States is why safer consumption sites and why now? And of course, as this slide says, if people have nowhere to go, they have nowhere to go. And if we're not giving safe, dignified environments for people to use drugs, then we see them in our public bathrooms, we see them in our parks, and we see really astronomical and preventable fatality rates. So the time is absolutely now. As we know, the concept of safer consumption or drug consumption rooms is not new. The first opened in Bern, Switzerland in 1986. There are over 120 sites all over the world, and there has never been a fatal overdose in one of those sites ever. And of course, that remains true for the sites in New York City. There's also a veritable mountain of peer-reviewed and scientific evidence. It's probably the most evaluated intervention for people who use drugs other than traditional treatment and detoxification services. And all of the evidence, generally speaking, is largely in favor of these sites. They are lauded for improving public safety. They are lauded for increasing overdose deaths. They are lauded for being a very vital and necessary connector piece between vulnerable people who use drugs and the stabilization services and the further care that they need. My favorite thing about the Safer Consumption Service is that it's an infinitely scalable and adaptable intervention. They don't all look the same, and they shouldn't all look the same. They should be built and conceived with the very unique needs of the specific jurisdiction and of the specific population that will use them in mind. So in New York City, we've chosen to stand up 2 fixed site locations. We have one in East Harlem and one in Washington Heights. We've opened a more traditional medical model, and we'll talk a little bit more about what that is in a moment, as well as a peer or consumer-led model. But that is really just the tip of the iceberg in terms of how safer consumption services can be stood up and applied to address the crisis. They can be co-located within a housing or a sheltering setting. And of course, we know in the United States, the vast majority of overdose fatalities are occurring in a housing setting behind closed doors with people who are alone. So co-locating consumption services within housing and sheltering settings makes a lot of sense to abate the crisis that we're currently facing here in the United States. You can also co-locate consumption service within a medical facility or a hospital, and there are a couple examples of this around the world. I'm a big advocate for this model because, of course, people who use drugs have other medical needs and other concerns that they need addressed separate from their addiction issues. And co-locating consumption services in a medical facility or hospital really promotes sort of finishing treatment and care in a hospital setting and getting other health concerns addressed. And it's not antithetical to co-locate harm reduction or drug consumption services with an abstinence-based program. Insight in Canada is the best example of this, the best and biggest, but this is increasingly a popular model in other parts of the world, and this is the next model that On Point NYC would like to open. So this is traditional detox and treatment co-located in the same facility as a consumption site and operated by the consumption site. And that's a very, very successful model. Pop-up and crisis intervention, that's the very simple tent and table that's erected kind of overnight when a problem issue has been identified. This is something that would have application in Skid Row in Los Angeles, Kensington and Philadelphia, areas like that. Oh. There we go. So here's Insight. You can see the safer consumption space on the bottom floor with the detoxification services directly up above, and then a long-term treatment program on the third floor. And this model really capitalizes on that moment of change talk that can sometimes present following a drug-involved medical emergency or overdose, when somebody may be interested in making changes in their addiction and in their life. Co-locating abstinence-based services with safer consumption services really allows you to not miss that window. Oftentimes, certainly this is true for us in New York City, and I'm sure it's true for you in New Mexico, when someone wants to go to a detoxification or treatment program, it's often a phone call and a check of insurance, and do we have a bed, and yes, maybe I can get you there, and all of these sort of barriers and hoops we have to jump through. We are a big proponent for eliminating those and co-locating services together. Of course, the mobile model, yes. Mobile model is really effective, especially with paired with smaller fixed sites and other models. This just allows you to avoid the headaches of finding buildings and dealing with the Bureau of Buildings and finding a landlord who's going to allow you to open this kind of program in their space. It also tends to be a little bit cheaper. You don't have those overhead costs, and you can roam around and follow the challenges wherever they happen to pop up. I want to draw your attention to the slide on it's my right. You can see the aftermath of a very busy moment for us on our safer consumption vehicle, which we call the Winnie, the Winnebago. So on this particular morning, we had 11 overdoses within an hour and a half and 2 heart attacks back to back. We triaged each of those medical emergencies ourselves. We did call 911. We knew something very strange was happening in the drug supply. We quickly found out that borax had been cut into the heroin supply in the neighborhood, which was, of course, causing this massive spate in overdose and other emergencies. I point this out and I put this slide here because halfway through our very challenging morning, EMS, the emergency services, told us we're going to stop dispatching ambulances to your site because you're triaging this emergency very well on your own. Instead, we're going to redirect our resources and our ambulances to other parts of the neighborhood that are getting hit and don't have this service there to triage these overdoses as they're happening. So they essentially said, you got it, you're doing a good job. You as a program are managing this on your own because you have the consumption site and the training and you're catching these incidents early. So we are not going to direct resources to you. They had said to us by the end of the morning, call us when you want to transport people to hospital. Thank you very much for doing what you're doing. We're going to go take care of the rest of the neighborhood. And all 11 people survived. The virtual model, very important for, I think what is are colloquially referred to as the rurals. I think that's what you call them in New Mexico. But the virtual model is a really new innovation that is being applied in Canada, the US, and parts of Europe. This is a great model for jurisdictions where there aren't established harm reduction programs that can shoulder a brick and mortar program, but where you are still seeing problematic overdose fatality activity. The other great thing about the virtual model is that it's still very participant and participant driven. So you can see with the 2 icons in the middle that the person sort of consuming drugs is still controlling and leading the interaction. So with the virtual model, the person consuming drugs develops a care plan, dictates who they will allow to be called if they're having an emergency, which hospital they would like to be taken to. You can tell them where your secret key is hidden at your house, all of those kind of details that will allow your rescue, so to speak, to be effective should you activate it. So if you are not interacting with the app, the platform, or the switchboard operator in a timely manner, your care plan will be activated. But if you continue to press that you're okay and to interact, no care plan will be activated and you'll just be left on your own. Really innovative and really successful model for rural jurisdictions. For our site specifically, how do they work? As I said, we opened 2 sites on November 30th, 2021. Couple unique features of our sites is that they're polymodality and polysubstance sites. So they're not injection sites. You can smoke, snort, sniff, inject, or otherwise consume any drug in any quantity in our site. We don't police quantities because, of course, if we did, we run the risk of bouncing people who are about to embark in a very dangerous activity away from our program. So we end up defeating our purpose, which is, of course, to keep an extremely vulnerable population as safe as we can. We don't provide drugs. I don't think we need to clarify that point anymore, but just in case, that's not the end of the business that we're in, although we are big proponents of the idea of safe supply, and we are big proponents of the idea of substitution therapies using prescribed medications to decrease people's dependence on the adulterated and toxic, illegal, and illicit drug supply. We do permit splitting in our sites. That means two people can go in on a dose of drugs together and they can split them in the site. This is an important safety mechanism and it allows us to sort of curb the encroachment of drug dealing like activities within the program site. And I can answer some more questions about that later, but for now, we'll just leave that there. Safer use assistance and training is permitted up to and including the point of administration. And this is very much a piece of public health education for people. This is not enabling drug use. This is teaching safer technique to help people survive their drug use and navigate their drug use in such a way that their brains, lungs, hearts, skin, teeth, limbs are all intact and healthy. We have extremely highly trained staff at both our locations, both the medical model and the peer-run site. We train everyone to respond at the level of a registered nurse. They are not all registered nurses, but we believe very strongly in giving clinical and professional skills to paraprofessional people. It's this high level of training, all designed by us and given by us, that has really allowed us to decrease our dependence on not only naloxone, but emergency services in the hospital. And we'll talk about that in a second. I'm going to jump down a little bit and just say, in terms of how our sites positively impact the neighborhoods where we operate, all supplies that we distribute to people in the OPCs stay in the OPCs. So no syringes, no cookers, nothing leaves the OPC. It all stays there. The other big benefit of the OPCs is because there are no time limits, we essentially have a captive audience for the duration of the time that a participant is there. And that is when the magic happens. That's when the beautiful boost side care, the clinical care, the mental health care, the housing applications, the benefits navigation, all of that deeper dive clinical mental health and case management work happens at the same time as drug consumption. And we would even go so far as to say it's allowing the drug consumption itself that promotes a sort of environment where this previously unconnected to care population is even willing to engage in further care. The last feature that I'll really illustrate and really emphasize about our sites is that we don't just have two overdose prevention centers standalone just in the middle of a neighborhood. Our programs are co-located within our larger program, and the larger program is intended to be dynamic enough and broad enough that we're delivering holistic care to people who use drugs. So our overdose prevention centers are co-located with showers, a drop-off laundry service, barbershop and hair salon, which will be opening next year, respite rooms where people can sleep, supported by THC and cannabis supplements to soothe the system and promote sleep, particularly with stimulant users who can be on those longer-term sort of long-term periods of use. You really need to calm the system and promote sleep as an intervention. It's a very powerful intervention. We serve food. We have job training. We have clinical care on site, a pharmacy on site, bees on the roof, a free holistic program, recreational groups, all of this located in one space. And really, the Overdose Prevention Center is in many ways the least interesting thing that's happening in the building. I'm going to skip over this because we don't have too much time, but as I said, we did open two sites. The Washington Heights site is our consumer-led site. What that means is most of the people working on that team are actively using the site as well. They are also trained to respond at the level of a registered nurse, and the consumer-led or peer-led model tends to be the cheaper of the two models to stand up, and you don't have things like licensing considerations with nurses and doctors and other clinical personnel. And it's a very simple tables and chairs, as you can see here, but the room is still clean, well designed, well laid out, and a very dignified space for people to be. The East Harlem location is the more traditional medical model. This is the more what you would expect to see in the media with the big stainless steel booths and the big mirrors. This is a slightly higher cost. It's a design build often, and there are medical licensing considerations with the staff on this site. Of the two sites, this is the busier location, and you'll see this in the next slide. But this location is a high volume inhalation population, and they account for fewer of the overdoses overall. The Washington Heights program is a high injection population, and their drug of choice is a speedball, which is a stimulant and a depressant. And though it's a smaller cohort, they account for many more of the overdoses, particularly because the mode of administration is more risky, as is the preferred drug. And this is the East Harlem location here. And in the back, you can see the smoking room. Because our sites are polymodality, I'm just going to move this out of the way here. We have smoking facilities on site. East Harlem, being the higher volume inhalation program, has a communal smoking room that it can accommodate 4 to 5 smokers at a time, and individual smoking vestibules for people who may need some privacy or need to be on their own for other reasons. They have a dual airlock system, special ventilation, and an intercom to keep all of the particulate matter and the vapor that's being combusted in that room from, it prevents it from seeping into the larger chamber. Almost done here. So since launching almost a year ago, we're just 2 weeks shy of our 1-year anniversary. We've enrolled over 2,000 people. This is something we're incredibly proud of. Because this is 2,000 people who, previous to working with us through the OPCs, really were not connected into any sort of substantive other care, whether it was case management, medical, mental health, or even really accessing addiction treatment or medication-assisted treatment. The sites have been used over 45,000 times, and that's 45,000 instances of public drug use that were picked up out of the public sphere and put down somewhere private, safe, and dignified. This has removed a huge piece of work off the plates of emergency services and ambulances, the hospital system, and law enforcement. We are estimating, going on to this next slide here, you can see we've done 603 overdose interventions since we opened, and we've only called the ambulance 9 times. I want to emphasize that those 9 ambulance calls were for reasons not related to the overdose itself. The team had successfully resolved the overdose, but made a call that underlying sort of health conditions or other presentation and symptomology would benefit from sort of overview from other medical professionals. That's it. Every other medical emergency and overdose, we resolved ourselves. We're estimating that an ambulance call, trip to the ambulance, stay and emerge, possible admission for a serious overdose is between $30,000 and $45,000. So just in diverted costs from EMS and the hospital system alone, these two sites have saved New York City almost $18 million so far. This does not include the savings to law enforcement. I'm not sure what it's like in New Mexico, but when an overdose is called in here to 911, a detective team, cruisers, and other officers are dispatched to the overdose call because of the fentanyl task force. That's very, very expensive. We would sometimes see 3 or 4 cruisers, 11 officers, 2 detectives arriving to an overdose call, and we no longer see that anymore. I will also say that our relationship with NYPD is one of mutual respect and collaboration. We work very, very closely with them, and they are a huge supporters of the site. Since launch, this is where the benefit to the public really becomes quite clear. The sites have diverted 1.47 million units of hazardous waste from parks and public spaces in New York City. This is hazardous waste material diverted directly from the OPCs, and this also represents the work of our outreach and public safety teams who are working in the 3 neighborhoods where we operate: East Harlem, Washington Heights, and the Bronx. We are big believers that if you're going to open a consumption site, you have a responsibility to open an outward-facing program as well, because of course we open these sites for 2 different stakeholder groups. We open them for the people who use drugs who are going to use the overdose prevention centers, but we also open them for the residents, the businesses, etc., in the communities where our programs are operating. We need to meet 2 sets of needs with these interventions. just quickly, I'm going to go back to this here. So this needs to be updated. We're actually up to 87% of OPC participants were connected into other services directly from the OPC. And these were people who were not previously connected to any kind of care before. These are direct linkages and pickups from the OPC, from detox and treatment providers. We changed the way we were working with people who use drugs, and we are very proud to say that detoxification and addiction treatment service providers in New York City also changed. So now they come and sit booth side with people in our OPCs when somebody has indicated they're ready to go into treatment, and they're very, very patient, and they do all kinds of motivational interviewing and all kinds of sort of anxiety management with people until they're ready to get in the vans, and they sit and they wait. So there's not this adversarial relationship with detox and treatment providers in the area. There's really this sort of symbiotic collaboration around seamless care for people who use drugs. We did notice that the overdose occurrence rates when we first started working with this cohort were very, very high. Around the 7 to 8 month mark, we started to see that plateau, and now we're seeing a very significant decrease. So of the 603 overdoses I was mentioning, the vast majority happened in the first 7 months of operation. So what we're seeing is the OPC is working to stabilize people. It is working to connect them into other care. It is working to help them practice maintenance drug use and to get away from survival or peak and valley drug use and to decrease their drug use. And lastly, I'm very proud to say that we are hiring directly from the Overdose Prevention Center, and anyone who visited our site from New Mexico the other day met many, many folks on the team who were Overdose Prevention Center participants who were stabilized through that program and eventually were hired to earn full salaries and living wage jobs working full time with On Point NYC, giving back to their community. It's not easy work, but it's important work. Lastly, I'm sure there are questions for how on earth we managed to pull this off, considering that we don't have federal or state permission to operate these sites. I'll pause there and just see if there are any questions, but I'm certainly happy to talk about that. I'm 9 minutes over time. I'm very sorry. Thank you so much for your attention, and I'm happy to answer some questions now.
Thank you, Kaylin. And actually, I think it's perfectly fine to be a few minutes over. Like I said, we've left some time with regard for questions. So if people have questions, if you can raise your hand, and then what I'll go ahead and do is I will see about calling on you for you to be able to go ahead and speak. Okay, Roberta Griego, you have a question.
How the heck do you guys do it without federal or state permission? Number one.
That's a great question. Thank you so much for that question. So for anyone that doesn't know, we made the most of a very unique and time-bound political moment in New York State. So we had an outgoing mayor, this was de Blasio at the time, who really had future political ambitions and sort of felt like he needed a big hurrah after being accused of being a lame duck mayor and really making a mess out of COVID and making a mess out of Black Lives Matter. And in his last 2 months of office, he decided that he would throw his political weight behind opening overdose prevention centers. That is one piece. The other piece is we sort of had Como over here accused of being handsy, and sort of the state government at the time was in absolute chaos and no one was looking at us. So we sort of had chaos at the state level. We had a mayor who had 2 months left to make big moves. We sort of knew we were being used by the city of New York, but we allowed ourselves to be used on our terms. And we really saw that this was the moment to get these sites open, and we would be fools if we didn't take it. We also did a political analysis at a federal, state, and local level, sort of this very Game of Thrones, who's in power now, who's on their way out, who's coming in, who's a supporter, who's neutral, and who's a detractor, and who do we think is going to come after us and make problems for us. I bet nobody in New Mexico knew that these sites were going to open until you heard about it in the news. We kept it very, very quiet because we didn't want to give the opportunity for mobilization against us. So we kind of harnessed political will where we knew that we could, and we pushed it through. From the second we decided as an organization we were going to do this to the day the sites opened was 7 weeks. That included building 2 locations, writing the policies and procedures, freaking out, trying to figure out a legal protections mechanism, training all the staff, and actually launching the sites. Please bear in mind that all we had when we opened was a very mealy-mouthed letter from the de Blasio administration, and de Blasio, he was only in power for 2 months before he left office. Then we operated for many months under the Adams administration with no sort of official legal protection, nothing on paper. And we had nothing on paper from the NYPD. We couldn't get anything on paper from the NYPD. If we didn't have federal authorization or state authorization, there was no way local law enforcement could put pen to paper in terms of indemnification, protection from prosecution, or anything like that. So we, as the provider, incurred all of the risk and had to decide how comfortable we would be incurring this risk with these levels of assurances, which were essentially just conversations. So it was, you know, we are still at considerable risk. We knew Hochul was coming in and probably going to stay. We knew Hochul was soft on the issue, and we knew Hochul would adopt a stance of non-interference. And we're very grateful to her for doing that, and we're seeing lots of states adopt that stance. Rhode Island did adopt legislation, but the legislation has its challenges, I'll just say that. And we're seeing other states looking to the cities to take a lead on this. And even Hochul has gone so far as to say, look, it's up to the cities to decide if the crisis in their local jurisdictions is enough that it warrants this kind of intervention. Healthcare is a jurisdictional issue. The state does not want to get involved. And that's exactly where we want the state to be. We did leak our policies and procedures and pictures of the site up to a certain level within DOJ, not too high, just high enough that we knew it would be taken up the chain. And we did the same at the ONDCP, just poking the bear a little bit to see if it would elicit a reaction, and it didn't. We also looked at 2 very important precedents, of course, being Safe House, Philly. We also looked at Rhode Island being visited by the FBI. We also looked at surveillance of the underground San Francisco site, and we also looked at our own experience operating 2 unsanctioned sites for 6 years before we launched the official sites. We, at the end of all of that kind of analysis and sort of nail chewing, decided that the court of a public opinion was on our side. The state was not going to interfere. We had the full backing of the city, and that the feds would come, but probably not issue a cease and desist letter or in any other way interfere against the sites. Remember, this was the first year of tipping over the 100,000 fatality mark. It would not be a good look against those numbers to come after what is quite really, in the grand scheme of things, a small organization trying to save lives. And that's ultimately the risk we took. I mean, it's stressful. Every gray hair on my head is from this year of running these bloody sites, but it's, you know, so far so good. And DOJ has come. The Department of Justice has come. ONDCP has visited. They stayed for 6 hours. It was a beautiful and challenging visit with great questions. And the end of the visit was all around, how do we regulate this? And I think that's a really positive place to end with a visit from DOJ.
Thank you so much.
It's a very
Caitlin.
long-winded answer to your question. I'm sorry, Roberta.
No, that is great.
Thank
And it's
you.
great information. I know several people have been on that are on the call have been nodding their heads. It's very appreciated. The next question we have is Brandon Warwick. Brandon, go on ahead.
Hey, thank you for the presentation. I was just wondering, one of the outcomes that many places will report on is number of people that they got successfully engaged into treatment and ultimately into recovery. I noticed that wasn't in your slides. I was wondering if you could comment on that. And then the secondary would be, when you start engaging them, if you began looking at cost savings estimates for with needle exchange applicability, cost savings with HIV, hepatitis C as a bloodborne pathogens?
Yeah, those are great questions. Thank you for asking. Two things. We're not even done our first year. It's way too early to be speaking with any kind of confidence about some of those more longitudinal questions, right? What I can say is that the sites can and do connect anyone that's interested in detox treatment or medication-assisted therapies, treatments, within minutes of indicating their interest. And we work so closely with a network of treatment providers in New York City that they literally will come and pick someone up within 30 minutes of calling them. And they'll come into the OPC to collect them. We as a program, we screen, prescribe, and induce for buprenorphine on site. And the clinic that does this work, operated by us, is on the other side of the wall from the OPC. And if you don't want to go into the clinic and sit for sort of a traditional screening, the doctor and the nurse will come to you in the booth and do the screening and the induction there. So what we're really describing is patient-directed care for people who use drugs. What is challenging for people to get their heads around is the fact that allowing the drug use is a precursor and is the foundation for being able to do all of this work. 100% of the people who are using our OPCs right now, that over 2,000, I think it's almost 2,100 people registered to the OPCs, 100% of them have been to detox treatment on methadone, on buprenorphine, many times. The role of the site is not necessarily sobriety, as I know you know, that's not your question. I do understand that. The role of the site is engagement, safety, and stabilization, and it's from stabilization that the likelihood of sustained periods of sobriety becomes a little more tangible. So what we're seeing, yes, we're connecting people to buprenorphine. Yes, we're connecting people to methadone. Yes, they're going to treatment centers. Yes, that is all happening. But for us, where we start to really get excited is where these periods of sobriety for this population get longer and longer between instances of return to use. We are working with a very specific population. This isn't sort of like my Aunt Tilly on a Sunday afternoon with a gin and tonic and a benzo. Like, this is chronic and relapsing, decade-long, very serious addiction. So from my perspective, I am extremely excited about some of the early impressions that we're seeing about the way the sites are interrupting chaotic drug use patterns and stabilizing an entire population who previously could not achieve stability. We are now so close to getting people housed who for years we couldn't even get into a shelter. If you are in chronic drug use in New York City, you cannot be sheltered. You cannot be housed. You are unemployable. There are no treatment center will take you because of behavioral things and blah, blah, all of these complicated things. So allowing the drug use in this setting, consistent and reliable access to this healthcare program, this is a healthcare program for a very specific population, is creating stability in such a way that positive, meaningful, and sustained engagement with these further care pieces is more likely, lasts longer. I'm going to stop talking. I think you get what I'm saying, but this is my soapbox because everyone is coming to us saying, yeah, the needles. Yeah, the overdoses. But what about recovery? And what about the longer term questions? We're not even a year in yet. NIDA is evaluating our program. We're grateful to them for doing that because it gives us a modicum of federal protection if we're being evaluated by a federal agency. But you know NIDA doesn't play. NIDA is coming in and they are going to rip the sites apart and they're going to be looking at exactly what you're talking about. They're also going to be looking at quality of life issues. They're going to be looking at law enforcement, petty crime, and recidivism. They're going to be looking at syndromic data from the hospitals. We're also being evaluated by the New York City Department of Health in partnership with New York University, and that is also a longitudinal, really looking at those longer term outcomes, really around connection to care, retention in care, recovery and sobriety. So more on that later, but the early impressions are really positive.
Great. Thank you, Kaylin. And Phil Feudy, you are next.
Here we go. Hi again, Kaylin. I'm not going to ask you the same question this time. I think the first time the information is really well woven into the data and as kind of secondary to the things. But when I first saw you present, I heard someone responding to a question about NIMBYism stuff and like in location, and I was really struck by, you phrased it as, if you really listen to what it is people are looking for, this is actually what they're looking for. And if you would summarize that again in that way, I thought that stuck with me as being really powerful. Thanks.
Thank you, Phil. Nice to see you, and thank you for that prompt, because it's really true. I think the biggest lesson for us was that a reframe was necessary, almost resident by resident, almost business by business, because people fear what they don't understand. They fear what they don't know, particularly around addiction and drug use. And up until November 30th, 2021, there was no American example to look to. All of the examples of drug consumption sites were outside of the United States. So for our first year of operation, we've had a completely open door policy. We've done over 400 tours. We let everybody in, particularly not preaching to the choir. So not preaching to Phil, right, who I know understands what we're doing, but really preaching to people who don't get it and would position themselves as the opposition. Allowing them to come in, feel the room, meet the staff, see the participants, and really, face whatever comes up for them. And as a part of that was this sort of like call to people who didn't identify as supporters to say, look, I know you don't think this is the solution you're asking for, but this is the solution you're asking for. You don't want public drug use. You don't want syringes in the street. You want your children to be able to go to the playground without seeing, public drug use and improperly discarded syringes. You don't want overdose fatality anymore. This is a part of that solution. You just might not have known that this is what you were asking for. The other reason why we sort of got away with some of this more sort of like brash or bold messaging to the community is that we were a long-standing provider in both neighborhoods. So our East Harlem program is 36 years old. Our Washington Heights program is almost 20 years old. We'd been in the neighborhoods for a really long time, so we kind of couldn't be NIMBY'd out. We had the privilege of saying that what we were doing was really a formalization of something we'd been doing for years. So New Mexico, as you go forward, if you consider this intervention, really find a provider who's got deep roots in the neighborhood, because NIMBY is going to come for you. But it's really helpful if you've got established relationships in the neighborhood. And bringing the community in and allowing those tough conversations to happen. Sometimes people would be there for 4 hours, the community boards, the police, the principal at the school. Our site in East Harlem, hold on to your hats, team, is across the street from a daycare. There is a consumption site in New York City across the street from a daycare. Our site in Washington Heights is across the street from a playground and a block and a half away from 7 schools. And what did we do? We partnered with those schools. So we are there in the morning, staff from the consumption site, cleaning up syringe litter, meeting with parents, helping the crossing guards. We know we have integrated loud and proud into the neighborhood because that's part of our role, right? Diversifying who the neighborhood thinks we are and what the neighborhood thinks we're good for. And a lot of that has really helped kind of digest that message of you don't think this is what you wanted, but it's part of the solution.
Great. Thank you, Kaylin. Anybody else have any other questions? I know there's been a couple of items in the chat, but I've been answering some of those as they go. Okay, well, Kaylin, thank you again so much on behalf of all of us. We really appreciate your presenting. Now, you are welcome to stay because once we go through just a couple of the usual things like the introductions and attendance, those sort of things, we're actually going to get to our subcommittee update. And the first one is our fentanyl subcommittee, which does have a recommendation about OPCs. So you are welcome to stay if you would like, but we understand if you are not able to. So don't take that as a you must stay. But
no, it's all right. I'll leave you to it, but I do want to just leave you with this. And I think you all know this at this point, but you are very welcome to come and visit. We would love to have you. And I know sometimes that like needs to speak to like. So I see lots of folks here from DOH. If the DOH would like to talk to the DOH in New York City about what it was like for them to support us to open these sites, please don't hesitate to reach out. We're happy to connect you with them. And same for PD. If PD in New Mexico needs to talk to PD in New York City about what it was to wrap their heads around this, and city councilors, etc. So please don't hesitate to reach out. We're here to help in any way. And thank you so much for your time.
Thank you, Caitlin. And before you go real quick, Aria, you had a question? You have your
I
hand up?
just wanted to thank you, Kaylin. We actually traveled up to visit the site in Washington Heights pretty recently. I was part of the little DOH group that went up there. I'm meeting with your folks on Monday to talk about the data and sort of some preliminary findings from that report that you're hoping to issue pretty soon.
Yeah.
And I wanted just to follow up with you. I just wanted to say hello and thank you just face to face. I am planning to follow up with you because we are thinking about, what legislation might look like in New Mexico. I might want to talk to you and sort of definitely utilize anyone who's willing to travel to New Mexico if we get that far in committees and so forth. That would be extremely helpful. But still don't have a green light from, from the powers that be. So still sort of in planning, thinking, percolating mode, and would love to talk to you about it. So
understood. And we, not just myself, but we are all here to help. We do a lot of technical assistance around this. We have a ton of experience with that stuff and lots of sort of cautionary tales around developing legislation. We do like to just always emphasize that we are unregulated and unlegislated at the moment.
Right.
And the sky did not fall. So we want to be really cautious about not legislating this initiative into the ground, but of course, knowing that some legislation is going to be required at some point. So yeah, reach out, and it's very good to see you. And
Yeah.
I'm glad you enjoyed your visit.
Thank you. Yeah, I'll talk
course.
to you soon. Bye-bye.
All right. All right. Thanks again. Goodbye, everyone.
Thank you, Kaylin. We appreciate it. Have a great weekend.
You too.
Okay, and thank you again, everybody else, for that little change in our agenda. I'm just going to share very quickly our minutes just on the screen, but please remember they are located on the website and they were in the invitation so that everybody can read through them there. I'm just going to show them right now while we go through so that people can actually read through them a little bit. Like I said, if you can access them through the website so you can see the full minutes without me scrolling, that's appreciated. In the meantime, I'd like to go very quickly through our board members to ensure that we have everybody on record for being present. And so I'll start Monica Arancon-Smith. Okay, Neil Bowen. Elizabeth Boyce.
Present.
Thank you, Elizabeth. Mackenzie Chase Enriquez. Ernie Dole. Elizabeth Dyer. Phil Feudy.
Here.
Thank you, Phil. Leslie Ann Hayes. Steve Jankowski. Joanna Katzman. Liz Lacouture.
I'm here.
Thank you, Liz. Welcome. Andrea Maloney.
I'm here.
Thank you, Andrea. Welcome. Sharan McCracken. I can see Sharan in the attendees, so I'll mark there unless I get something otherwise. Scott McFall.
Present.
Thank you, Scott. Welcome. Darcy Pope Wyatt. Charles Shoemaker.
Here.
Thank you, Chuck. Randall Starling.
I'm here.
Thank you, Randall. Brandon Taylor. Brandon Warwick.
Here.
Thank you, Brandon. Welcome. Jennifer Weisberg.
I'm here.
Thank you, Jennifer. And then myself, Dominic Zerlo. So that does give us 11 individuals present. So we do have a quorum and have since towards the beginning of the presentation. So we'll be able to continue moving forward. I hope everybody has had a chance to review the minutes from the last meeting. Are there any concerns, questions, or changes for those minutes? Okay, can I have a motion to accept the minutes as they are?
Motion to accept.
Bill, thank you for motioning. Any, sorry, do I have a second?
I'll second.
Thank you, Jennifer. And so at this point in time, are there any objections to the minutes? If not, if there are no objections, we can consider the minutes accepted by unanimous consent. And that actually brings us to the next item, which is council membership status. Our membership is still at 100%. And so at this point, there are no vacancies. And are there any questions with regard to council membership? Okay. Well, with that, we'll move on to subcommittee updates and recommendations. And Phil, that does bring us to the fentanyl subcommittee. So you are up first with the recommendations for the Overdose Prevention Center and the recommendations on MOUDs. So go on ahead, Phil. I'll turn this on over to you.
All right, thank you. Let's see. So we just had the presentation from Kaylin and the On Point. I don't know if anybody that's on this call happened to participate in the Drug Policy Alliance's did a one last week on the same issue, but it was with Sam Rivera from the clinic, the director there, and it was also equally as phenomenal. So I think there may be even a recording available of it, and if I can find that, I'll put it out, put it down on our list. So our first recommendation is looking at recommending that we look into and hopefully establish overdose prevention sites here in New Mexico. And I don't know if anyone had any specific questions about that right away. And can you scroll through that briefly, Dominic, just so we didn't do it.
I did have one question. I read through it and it looks like, so I don't see like a budget or anything attached to it. Are we asking for any money?
Jennifer, we actually can't request the budget. This is just a recommendation that it move forward as far as for proposal. But we're not able to ask for funding specifically unless it goes through the governor's office first.
Okay, so if the governor is on board with it, then we would need to propose estimated costs and things like that, locations.
Right, then it'll move forward from there. Again, it would depend because depending how it would end up being set up would make a huge difference in budget. For example, would the statute simply allow for local community organizations to be able to set these up and do them, or would it be required that a government agency set it up? And those would require vastly different budgets, and one or the other might actually create, potential conflict with regard to that. But that's a great question, and yes, we would continue to work as far as budget items with the governor's office and with the policymakers.
Thank you.
Just a follow-up question. there, Dominic, and understanding the budget. When or if it's probably better of a when the opioid settlement money starts coming in. My understanding is that that's going to be channeled through HSD, and and I know Neil Bowen's not on the call, unfortunately, but then would HSD be able to dole out some of that money for such for some of this with or without or with or I guess the question is, would they at that point need the governor to sign off, or as a revenue stream, or I don't know how that money would get then divided up.
Sure, not a problem. And that's a great question, though, Brandon, about it. Those funds could potentially be utilized for something like this. However, at least my understanding, and it would need to be done through a budget through HSD. So if that were to happen, then they would, of course, negotiate that independently. And that's one of the reasons why there's not a budget specifically on here, because again, it would depend on where the creation of the OPCs would end up. I hope that makes sense.
Yeah, that does. That was kind of what I was anticipating happening. And based on that answer, I mean, I think it gives more of more timeliness to push this forward, even if we don't have a budget, and to make sure that the conversation is continuing, ongoing, and that we're looking at multiple budgetary options.
Okay. And
One more.
Oh, go ahead,
thought.
Jennifer.
Well, and I was just thinking, I know like, she said in New York that basically all the stars had to align just perfectly in order for them to be able to do what they did. And I don't know if we're gonna have the same luck that they did, but if we don't, is it possible to put in the recommendation that like if everybody's, a little too hesitant to move forward 100%, but just do like one pilot site or one pilot location?
Well, and again, Jennifer, that's actually specifically not in here, so that depending on what happens from the legislative, then it can actually be negotiated as to what would occur.
Okay, so we can negotiate
whether-
it during the session if it looks like it's not going to go anywhere.
Right, exactly.
Okay.
And to be honest, anytime New Mexico starts a brand new program, it's not done suddenly all across the state all at once. It's often, it's a couple of locations to start, work through potential issues, concerns, things like that, and then expanded from there. It's very rare for there to be any program that is suddenly able to happen statewide, and that's just due to logistics and many other resource factors. Okay, any other questions? Phil, did you have anything else with regard to this recommendation?
Nope. I think Chloe actually for doing a lot of the work, and that there seems to be a lot of data supporting this, and is just hearing Kaylin's presentation and stuff. I think it's absolutely doable. It's not like some of us don't have experience with this, and for many years it's been fairly common practice for harm reduction programs to more or less let people use the restroom in whatever way they need to use it. And there's even ongoing data and stuff about that. But again, fentanyl has kind of changed the game a little bit, and the idea of people locking themselves in a restroom and then not coming out, as it's become a much more problematic. And I think this would be the logical growth for our harm reduction programs. We've got almost 25 years of experience in the coming year with these services in the state, so it's pretty exciting.
We are at 25, aren't we, Phil? That is amazing.
Yeah.
So, okay. Well, thank you very much, Phil. Any other questions with regard to this recommendation? Do we have a motion regarding the recommendation? Oh, Brandon, you are on mute.
Yeah, I recognize I muted myself to forward the motion and end the awkward silence.
Not a problem. So I will take that as you are recommending, or you are moving that we accept the motion as it is, correct?
Yes.
Okay, do I have a second?
I second.
Was that you, Elizabeth Boyce?
Yes, Elizabeth.
Okay. Thank you, Elizabeth. Sorry, just checking and making sure because I heard the voice and it sounded familiar but couldn't see. Okay, do we have any objections with regard to this motion, or shall we consider this motion moved by unanimous consent? Okay, seeing no objections, this motion has been passed to be moved forward by unanimous consent. Thank you, everyone. And Phil, this brings us to the second recommendation, which I'll bring up on the screen in just a moment, which is the MOUDs.
Right. And, this has been revisited multiple times over the years. It's back when I was with Department of Health in the early 2000s, we were trying to negotiate with Department of Corrections. At that point in time, it was about methadone and stuff, but we have other options and things that are available now. So this one, with a lot of help from Anna and Roberta and input from others, is recommending that the state explore implementing MOUD treatment in corrections. I think in the PDF that Dominic had sent out, attached to the end of this, there was the poster that was assembled by a person who was with ERD, looking specifically at New Mexico rates of fatal overdose following incarceration. And I think it's very, very telling, actually. There we go. So looking at what was approximately a 3-year period, or I guess a little over, no, 2 years. You can see in the red at the center of the page that post-release, the rate of overdose death for post-incarcerated individuals, 446 per 100,000. Pretty sobering to actually see that, and to see that in our own state data.
Just a couple of comments to kind of bolster a little bit what Phil's saying. Nationally, and this has been the case well before the fentanyl era, and even well before the oxycodone thing, being released from jail is the #1 predictor of a risk factor for predicting an overdose. Essentially, they lose their tolerance. But as a voting member, my one suggestion, or actually it's a full-on recommendation, is that MOUD needs a further definition, and I would suggest any FDA approved treatment. The fact is, patients need to have a choice in this, or the inmates need to have a choice. And just because not all MOUD options are the same. I've got patients in my clinic who have been successful on methadone, but have failed buprenorphine, vice versa. And I would absolutely, or I would be very concerned if patients had no choice and the only option they had was Vivitrol or naltrexone. And if they're not comfortable, they're not willing to be on it, what's the and then they get released and they stop using it. When they come off the Vivitrol, they're at an increased risk for death as well. And so my point is, we need to have patients or incarcerated inmates need to have choice. And the FDA agrees with that as well.
So Brandon, this is Dominic. To me, that sounds like what you're saying is just for the recommendation itself, because there's not really, while it recommends a few of them within, it doesn't specify that it's only those, is that we just changed the language in the recommendation to it is recommended that the state of New Mexico ensure access and choice to medications for opioid use disorder.
Perfect.
Does that sound good?
Any FDA approved.
Yeah.
Okay, so access and choice to any FDA approved medications for opioid use disorder.
Yeah.
Within-
Yeah,
that-
and my
okay.
opinion is that I think there's going to be some correctional facilities that'll probably fight this a little bit harder if they have to do buprenorphine, because again, buprenorphine is the #1 drug smuggled in and through prison, so they're just adversely don't like it. But I think in the long term, it might, if we have to do a second year, it's going to pay dividends in the long term.
Yeah, that sounds great to me. Okay, so I've got that language in here. I'm sharing that screen. You should all be able to see that now with the modified recommendation.
And I see, Anna had put a note in the chat that is reinforced down in the implementation section.
Okay. Do we have other questions or concerns? Sharan?
Hi there, can you hear me?
Yes, we can.
Oh, excellent. Good afternoon. So my only concern with the word any, and I don't know if maybe this can be put into context somewhere else in the document, is the intent is not to like mandate availability of brand name medication, but to ensure access to, like if there's 2 approved drugs, then there should be access to both of those, not necessarily like every single version of every single dosage form, including brand name, because I think you're probably going to run into a lot more issues there.
So Sharan, just if we remove just the word any, that would make it, it is a recommendation that the state of New Mexico ensures access and choice to FDA-approved medications for opioid use disorder within correctional facilities. How does that sound for people?
Better.
Better? Any objection to that? Okay, that's a great point. Thank you, Sharan.
Thank you.
Okay, any other questions, concerns, edits? No. Okay, do we have any motions regarding this? By the way, Phil, just because you're chair, you can still move for this, for that subcommittee.
And I will move.
Okay, so I have Phil moving that we accept this recommendation from the subcommittee as edited. Do I have any, do we have a second?
I'll second.
Brandon, thank you. So we have a second. Do we have any objections? Seeing no objections, we will take this recommendation as unanimously approved and move forward. Phil, the subcommittee now has 2 recommendations from it to move forward to the governor's office. Do you have any additional items to bring up or speak about regarding the fentanyl subcommittee?
I do not. I thought it was very effective that we broke it into groups. It actually kept it going when a few folks that expressed interest in the beginning ended up not continuing to participate. So I think once we get onto the beginning of next year, we should revisit whether we disband it as such, or if people have new ideas to introduce in there, that we do that.
Great. Thank you, Phil. Is there a meeting scheduled, an upcoming meeting scheduled yet?
There is.
Okay. Okay. So we'll see about that in the upcoming year.
Right. Thank you, everyone.
Okay. Thank you, Phil, and thank you, everyone else. Our next item on the agenda is the methamphetamine subcommittee, which did not actually meet in between the last meeting and this one. So there is nothing to report, but anybody on that committee, do you have any items you would like to bring up at this time? Okay, well, we will move forward. Oh, I'm sorry, Phil.
I was just going to say, I think that we scrapped the one recommendation or sent it back to the drawing board for next year, and that was the exploration of medications.
That is correct, and we sent it back to explore next year.
Yes.
That is correct. Okay, well, with that, the next subcommittee report is the integrative pain management. And Michael Pridham, I do see you're on. I know you were going back and forth with some patients. Are you able to talk or speak and give an update?
And can you hear me with my speaker?
Yes, we can.
Okay, perfect. So we did not meet, but I did present in for the Medicaid waiver discussion with the HHS, I believe, and kind of advocated for the pilot project that was put into the budget. So that will be coming up in the legislature at the Roundhouse, and our next meeting will be shortly before the Roundhouse session begins, January 6th, 1:30 to 3 o'clock. And we will be able to kind of update everybody on any updates. So that's all I have.
Okay, great. Thank you, Michael. Anybody else from that subcommittee with any other items?
I have one, and it's not directly in the subcommittee, but I know Philip, Chloe, several others on the call are working on this. And I just want to make the committee aware of that what appears to be, or what we're seeing and have been seeing for some time, is legitimate prescriptions of buprenorphine are not being able to be filled at pharmacies in multiple places in the state. Catherine Lowry has put out a survey, and I don't see her name on here, but if she is, I'd happy to share some of those results. We've just had some meetings. Oh, there she is.
Yeah.
Catherine
is
we're having
on.
some meetings and things going forward as we can do this. I think the concern is that the state, in a very short period of time since Catherine has opened up the survey, have had multiple medical providers identify overdoses and relapses that have occurred as a result of this. Certainly, we understand that it's probably outside of the scope of the council to mandate that every prescription be filled. I mean, there's going to be federal law, and that's problematic because we don't want bad doctors, bad prescribers in this state either. But realistically, we need to be preventing the overdoses and relapses. I was hoping to get the blessing of the council with our efforts moving forward. Catherine, putting you on the spot.
Yeah, well, I'm actually, Brandon, I'm multitasking. I am literally looking at the latest data right now. The goal was just to be able, in the interests of public health, to be able to have a way to document. We know individual providers, have said again and again that, that this is an issue for their patients. But sometimes the pushback is you're just one provider, or it's really only a problem in Espanola. And even this very quick little online reporting tool, we've got people reporting problems across the state, north, south, east, west. Of course, several reports from Espanola and from Albuquerque, but definitely not restricted to that. And the other thing that I think is really helpful is that, so we've got about 30 responses at the moment, and that's, assuming that's a huge undercount because as Brandon likes to remind us, busy providers don't have time to fill out online reporting tools, even if you make them as short as you can. So, and I appreciate Phil and Athena also working on this with us, and a lot of people at DOH, as Brandon mentioned. But, it's just, again, it's documenting what I think everybody on the council is probably really aware. When people get a prescription and they go to the pharmacy and they're told their medication won't be in stock for another 4 weeks, or that they'll have to come back tomorrow, or the staff is rude and dismissive to them, or pharmacies simply stop stocking. All of these things really, really put roadblocks into people getting the care they need. And again, it's our hope, as part of the Department of Health, to just help document this and make the case for people who can be persuaded by some data. We do have, of course, the prescription monitoring program, but that only documents successful fills. And this is just, again, it was our attempt to find a relatively easy way to demonstrate the scope of the problem. And again, we know it's been ongoing, and we know it's causing harm to patients and frustrating the heck out of providers.
So Brandon and Catherine, are you really proposing that this be looked at for one of the subcommittees to develop a recommendation for the council?
I would almost just say we could probably be our own formal subcommittee right now, with Philip, Chloe, Catherine, and several others who are helping with that. And I would think that if we can get some resolution to this, we just dissolve the subcommittee.
But I mean, I think that is fine, and I don't have any issues with regard to that. Are there individuals who would be interested in serving on that for this one particular recommendation? So let me just make sure I get individuals down on this. So of course, Brandon, we've got you. Chloe, I thought I saw your hand up. Is that correct? Phil, did you have yours as well? Catherine? Well, I will include Catherine on the emails. She's probably jumped over to her other task. Oh, there you
no,
are.
I'm here, and also Anna Gear, because she's also been working on. Dr. Hayes has actually also obviously been part of these discussions. I don't know if she wants to officially be part of the subcommittee or not, but yeah.
I'll include her on an email sent.
Okay.
To see about that. Thank you. Anybody else? Anybody that I've missed?
I can't, I'll check with Ernie and Joanna, but they were the first two to bring this to the attention of the council back in 2016. But and they were looking at it for pain meds, but but let me check with them both, and I work with Joanna now on a regular basis, to see if they're interested.
Okay, great. And then just let me know, Brandon, and what I'll do is I'll hold off until mid next week, and then I'll send an email to those individuals who have expressed interest to see about forming this, to see about what meeting date and time. Okay. All right, any other business? Okay, so the final piece of business, of course, is our next meeting. And if we follow the schedule we have been, usually we are meeting on the second Friday of the month. This month was an exception because the second Friday was a state and federal holiday. But that would put us at January 13th at 1:30. Are there any concerns or issues with January 13th that I may have missed? It's not a holiday that I'm unaware of.
Give me 1 second.
Sure. Thank you, Brandon.
I have an appointment, but it ends at 1:30, so that works fine for myself.
It's great.
Okay, so we'll be looking at Friday, January 13th. That'll actually be just in time for the start, just before the legislature starts. So one of the things that I know has been requested in the past is that we have somebody just come and kind of talk a little bit about what the legislative process is like, what committees are like, hearings, and what as a council we are able to do and what we're unable to do. Does that sound appropriate for that meeting? I'm seeing head nods and thumbs up. Any objections? Okay, great. Well, thank you, everybody. Well, with that, unless there's any other items, comments, or suggestions. All right, well, we are complete for today. Thank you, everybody. I appreciate it. This is some great work, and I hope you all enjoyed the presentation. And we'll be getting those recommendations on over to the governor's office. In fact, I was just asked, even before we finished, when can I get those recommendations from one of our policy advisors? So I'll be getting them to them today. So thank you, everybody. Hope you all have a great day and a great weekend. I appreciate everybody who is here, council members and other individuals who are involved in this. Your attention and your work on all of the subcommittees and on the council is greatly appreciated. Thank you, everyone, and I hope you all have a great holiday season.
Thank you, Dominic.
Thanks.